it's been shown to reduce HCC risk. And this is a very interesting paper that was published in 2004 by the Taiwanese group, Professor Liao. Now, what about liver cirrhosis? Well, it increased, of course, it's the chance of getting liver cirrhosis increased with duration of active disease, about 8 to 20% accumulation over 5 years. Your patient will develop liver cirrhosis. And if you look at the patient who is not, that means who is well compensated, okay, the patient may be cirrhotic on ultrasound, on CT scan, or even on fibroscan or liver biopsy, but the labs are alright, there's no drop in albumin, there's no ascites, there's no portal hypertension, there's no ascites, and there's no jaundice. This patient have a mortality rate 5 years about 16%. But once the patient developed decompensation, the patient turned jaundice, have ascites, beta edema, the mortality rate actually shoots up very, very high. And we're talking in a range of 65 to 86% in 5 years. So these are very, very high mortality rates, and we need to look out for them when, look out for decompensation when we monitor patients with liver disease. Now, they're also at risk of developing ascites and variceal bleeding, something which can be very scary to the patient. You know, you just vomit out a large volume of blood for those with bleeding varices. And it increases with worsening ascites. And we know that about 25% of patients with chronic hepatitis B actually die from Hep B related death. So why, there lies, if you look at it, Hep B is actually not a good disease to have, especially if you have it for a long, long time, chronic Hep B. And therefore, we need to monitor them and to look out for times where we can intervene. So there are few reasons why we need to monitor them. We need to monitor them to catch them when they are suitable to start treatment. Because we know that when we treat them, appropriate treatment can actually improve the outcome. Again, this is from the same study published by Liao in 2004, where they look at the incidence of HCC development and the incidence of decompensation in patients who have chronic hepatitis B that was started on treatment. And if you plot the Kaplan-Meier curve, they actually diverge after a couple of years. And patients who are on treatment actually do a lot better compared to those who are not on treatment. So it is important that we catch them when they are suitable for treatment and intervene by treating them appropriately. The next is, of course, to monitor for early detection of complications. So we should institute intervention, early intervention if they develop ascites. We should screen and manage varices, screen and manage early HCC, and list them for transplant if we find that they are decompensating. So remember, when they start to decompensate, about 60 to 80% of them will actually have a mortality within 5 years. So these are the ones which we may want to put them on a transplant list. There's actually another point here, the third point, why we want to monitor patients with chronic hepatitis B. You may remember what Wan Cheng said earlier. 1% of patients actually lose their S antigen per year. And that's like, the ultimate, if a patient who has chronic hepatitis B lose their S antigen and develop S antibody, it is the risk of developing complications from hepatitis B actually drop a lot. But there's a word of caution here. It is not down back to the normal population. And it depends on the stage where the patient loses its S antigen. So if the patient is already cirrhotic and they lose their S antigen, then the risk of developing liver-related complication is still significant. So you have to note when the patient loses an S antigen. So, few things that we can do. For ascites, we can restrict salt intake. If they have ascites, we have a high degree of suspicion for SBP and institute prophylaxis. So these are the things which can cause which can have an impact in a patient. Variceal screening has been shown. If you screen and treat with prophylaxis, either you ban them or you give them non-selective beta blocker, the chance of rebleeding is much lower. So if you have a patient who is already a known cirrhotic and you do a full blood count and the platelets level are low, these are the ones which have a high risk of, if you scope them, there's a high chance you may find varices in this patient. Now, HCC, this is again one of the main things why we monitor patients with chronic hepatitis B. It's been shown very clearly that early detection benefits the patient. we are in the process of analyzing our data from Changi. We look at it about maybe less than a decade ago. We look at when we detect HCC, only about 20% of them are resectable. Most of them are not resectable because the size, by the time we discovered, they are in 8 cm, 10 cm, 12 cm large tumor that we can't do anything about it. But increasingly, if we look at our figures over the last 5 to 6 years, our resectability rate has actually gone up to about 60 to 70%, which means it's the reverse of the curve. And we know that if they go for surgical resection, the 5-year survival rate is actually quite good, in a range of 70 to 80%. As opposed to if you don't go for resection, a lot of them actually do not make it beyond 1 year, 2 years. So that remains the mainstay for effective treatment. And resectability actually depends on the size. It has to be less than 5 centimeters. The underlying liver disease, if the patient is already decompensated, if you take out more liver, the patient can actually go into worsening decompensation and die from it. And of course, anatomical consideration. If the tumor is near some major blood vessel, again, it is not suitable for resection. But size was, and size still is, the main one, which renders a lot of patients unresectable. Of course, following that is actually the liver, the stage of the liver disease. Now, we know hepatocellular carcinoma, the doubling time is about, on average, about 3 to 4 months. If you have calculated the median, is about 117 days. I don't know why 17, why not 120? Easier to remember. But it's about 3 to 4 months. Every 3 to 4 months, the tumor doubles in size. And that's the average. Of course, we have seen those who are more aggressive. Within 2 months, the thing has gone from, a small thing to a huge thing. But we have seen those also who have been very dormant and remain about the same size over 1 year, 1.5 years. But this is the average. 3 to 4 months, the guy doubles in size. And if you look at ultrasound, which is the tool that we use for screening, it reliably picks up tumor about 2 centimeters in size. So from something from 2 centimeters to 8 centimeters is in a range of 8 to 9 months. Alright? So if you do not catch them early, if you see them see them a year later, or they default their treatment, within a year they can actually come back to you with a very, very big tumor. Alright, and bear in mind early HCC is asymptomatic. The patient don't feel unwell at all. And that is one of the main problems, the main challenge we face when we follow up patients with chronic hepatitis. The guy will be there smiling at you, Why do you want me to come back every few times a year? Every time you tell me everything is okay, maybe it's not worth it. I can save a few $100. I don't need to come back. So the patient need to know very clearly why we are doing all these things for them. So in just a matter of slightly more than half a year, the patient can go from a curative resectability stage to a stage that is not resectable. Now, if the patient has gone into decompensation, it is time to consider transplant for this patient. That's because livers don't grow on trees. They need to wait. And you can't go to the road and shoot somebody and get the liver and give it to your patient. So there's always a transplant waiting list. And we need to list the patient early, because when the patient is too sick, the outcome will be poor as well. So the time to list them is when they start to decompensate. When the Charles Bill score is about 7, that will be a good time to start listing and working them up.